So the correct answer in this case is D, Van Hippel-Lindau. This patient has increased risk for Van Hippel-Lindau. Let's look at this lesion right here. Well, first of all, for core exam and for real life, whenever you see a core neoplasm or spinal neoplasm, you should decide its location. That can help with you with your differential diagnosis. In this case, this is inside the spinal cord, so it's an intramedullary mass. If the lesion is outside the core but inside the dura, you'll be intradura extramedullary. My differential diagnosis would be comprised of schwannoma versus meningioma, for example. If it's an extradura, then my differential diagnosis may be something like metastasis. So in this case, it's intramedullary mass. So your top two differential diagnoses in general for intramedullary neoplasm should be ependymoma versus astrocytoma. Hemangioblastoma is distal third. Now, this lesion does have a characteristic look of a cystic component with an enhancing mural nodule. So that's fairly good for hemangioblastoma, both in the spinal cord as well as in its brain. Most of the time in the posterior fossa, you see a cystic lesion with an enhancing mural nodule. In addition, notice that how small the enhancing lesion is relatively to the large amount of the core edema and syrinx it produces. And that's also somewhat characteristic for hemangioblastoma, in that sometimes you can have a tiny enhancing lesion with a disproportionate amount of either core edema or syrinx. So overall, this is the best for hemangioblastoma over other type of core neoplasm. Therefore, the answer is Van Hippel-Lindau. For hemangioblastoma, they can ask you the question on the core exam is that, remember, it is the third most common primary core neoplasm. It's distal third. In real life, it's relatively uncommon. Most likely, when you see an intramedullary mass, it's going to be either ependymoma versus core astrocytoma. Hemangioblastoma is a low-grade lesion, WHO 1, of a tumor of the vascular origin, so they tend to enhance avidly. And this lesion, hemangioblastoma, is an adult tumor. The peak age is about fourth decade. If you see a hemangioblastoma in kids, or if you see multiple hemangiomas, then you should think about the patient may have Van Hippel-Lindau. This is the same patient. You can see that the patient has another hemangioblastoma, a cystic lesion with enhancing mural nodule, most commonly in the posterior fossa. Also, somewhat characteristically, the enhancing lesion tend to abut the PO surface. Unlike, say, pilocytic astrocytoma, they don't often abut the peripheral of the PO surface. Hemangioblastoma does. So if I see a cystic lesion with an enhancing mural nodule in the posterior fossa, my differential diagnosis for adult and for kids is slightly different. For adult, I would be thinking about metastasis, number one, and hemangioblastoma as number two, even though hemangioblastoma is the most common primary intraaxial infatentorial tumor in adult. Metastasis is going to be more common just by number. For kids, the cystic lesion with enhancing mural nodule, most likely you will be pilocytic astrocytoma. Again, if the kid has Van Hippel-Lindau, then I will be thinking about hemangioblastoma, especially a cystic lesion with a small, relatively small enhancing mural nodule that abuts the PO surface. So those are the differential diagnoses for posterior fossa cystic neoplasm or cystic lesion with an enhancing mural nodule. Now, as far as the spinal cord neoplasm or intramedullary core neoplasm is concerned, the top three should be ependymoma number one, astrocytoma number two, and distal third hemangioblastoma. So to tell them apart on core exam and in real life, sometimes age is helpful. For example, ependymoma and hemangioblastoma tend to be an adult disease, whereas astrocytoma tend to occur in kids or younger adult. Again, if the kids or if the younger person has Van Hippel-Lindau, then the patient may have hemangioblastoma. Other location that or other feature that they like to talk about to distinguish between ependymoma versus astrocytoma is that because ependymoma is derived from the ependymal cell in the central canal, so its location tend to be more central, whereas astrocytoma tend to be eccentric. This is example of a 60-year-old person with ependymoma, biopsy-proven ependymoma. This is example of a 17-year-old with core astrocytoma. Notice that on the cross-sectional image, the ependymoma is more central in location, whereas the astrocytoma tend to be more eccentric. So on core exam, our goal is that location, but the truth is in real life, sometimes the lesion is big, it's very difficult to tell them apart. So essentially it's come down to a differential diagnosis rather than diagnosis. And in this case, sometimes you can talk about hemosiderin cap sign. So for ependymoma, it's a lesion that tend to bleed compared to other core neoplasm. So therefore, if I see the hemosiderin cap sign, I will lean toward ependymoma or potentially hemangioblastoma. That's another lesion that can bleed. Astrocytoma, on the other hand, tend not to bleed or calcify. Therefore, you tend not to see susceptibility artifact or this hemosiderin cap sign. And this is the best example that I have in my collection. You can see the cap sign is essentially, I hope you can see this small dark signal. So it's an O bleed or O blood product that has a hemosiderin stain that's staining around the both end of the cap. So the so-called hemosiderin cap sign. Not the best example, so I have to borrow a case from Radiopedia. I think most of you know about this site. It's a great resource to go for many different radiographic entities. In this case, this is a much better example of a hemosiderin cap sign. Notice that on T2 weighted sequence, you can see this hemosiderin cap T2 hypointensity that's surrounded by the tumor cyst or syrinx. Let's look at other answers that does not work as well in this case. For choice A, NF2. NF2 can produce three types of lesion: multiple schwannomas, meningioma, or ependymoma. So if you think about NF2, this intramedullary lesion must be ependymoma. So we already talked about why ependymoma is not the best choice in this case. For answer B, this probably is referred to spinal metastasis. So for spinal metastasis, the more common type would be extradura, so osseous metastasis, or if it's intradura, it tend to be extramedullary. So they tend to be leptomeningeal metastasis or the drop med. The actual core metastasis or intramedullary metastasis is relatively rare. So for spinal metastasis, I expect to see either a osseous metastasis or drop med. So choice B is not it. For ADEM, you are thinking about transverse myelitis, and I hope nobody here is confused this entity with transverse myelitis. You should never see a discrete enhancing lesion like this in transverse myelitis, and they usually do not produce syrinx to this greater extent. They typically do not produce syrinx at all. So ADEM is definitely not it. Lastly, for KRE1, as you know, KRE1 has increased risk for syrinx. Again, nobody should confuse this as syrinx in that you should never see an enhancing lesion within a simple syrinx. So KRE1 is definitely not the choice here. So overall, Van Hippel-Lindau or hemangioblastoma is the best choice in this case. That's all for this case. Good luck on your board exam. Thank you.